Good evening, everybody. Here's the title of the talk, as you already know. Just wanted to touch again on the disclosures for everybody. There's a whole raft of them here, but I just want to point out I'll be talking about the results of the Adagio study, and I have done consulting for Teva, and I'll be talking about results of a trial that were sponsored by Novartis also. So just want to bring those particular potential conflicts to people's attention. I've had a lot of different grant support and consulting regarding this topic. So, sorry, moved ahead. So here's a photograph. I can't ask people if you know who this is, but this is Tenzin Norgay, who is one of the first two people to climb Everest. I think his photograph's particularly interesting because he has this look about him of, he's got certainly a sense of humor from his smile, but also a sense of determination and humility, I think, which are all probably good attributes in facing difficult challenge. And here's a picture of him taken by Sir Edmund Hillary when he was at the summit of Everest. Actually, Tenzin Norgay was part of the expedition led by the Swiss explorers who came the second closest to coming to conquering Everest a few years before. But he persevered and joined this Commonwealth-based expedition that was eventually successful. So this has been a long process trying to find interventions which would favorably influence the course of Parkinson's disease, much less any neurodegenerative disorder. But persistence is important and success is possible. But we have to be able to know when we see it. So slowing progression in Parkinson's disease is not, on the face of it, a very easy thing to do. And I want to talk a little bit about the background here, about some of the difficult terrain. Everest certainly is difficult terrain, but Parkinson's disease is also, and explore some of the reasons why that is so. And what are the problems in Parkinson's disease? That is, what are the sources of disability? What are the clinical issues in individuals with Parkinson's disease? And what are some of the unmet therapeutic needs regarding these sources of disability? I'll just forewarn you that I have a lot of pictures of graphs, which if that's not a mode that works well for you, I apologize for that. It's one that works well for me, and I'll try to explain them as well if that kind of visual presentation does not work that well for you. But the next is a slide from a study that was called CALM-PD, but it was a study comparing the initial dopaminergic drug intervention in Parkinson's disease, comparing levodopa to the dopamine agonist pramipexole. And what this graph shows is on a vertical axis is a change in the Unified Parkinson's Disease Rating Scale, the so-called UPDRS. It says here the total UPDRS. And on the horizontal axis is months. So this goes out for about 4 years. So what this demonstrates is that the total UPDRS score in these individuals who started with a score of around 30, in the low 30s, is a moderate degree of Parkinsonian disability, that when they start either of these two drugs, levodopa or pramipexole, you can see there's a very prompt 10, even greater, 10 to 13 point improvement in their UPDRS scores. This is one of the important features that we can identify in Parkinson's disease, is that we have drugs that are very potent in reducing the signs and symptoms of Parkinson's disease as rated by this UPDRS scale, which largely focuses on the motor features of Parkinson's disease. So what you can see here, as I've already said, is that immediately there's a very great improvement in these scores on the order of 30 to almost 50% improvement, levodopa being more potent than pramipexole. And then despite adjustments in these two medications that could be made, despite the fact that the group that was originally randomized to pramipexole, shown here in green, could later add levodopa, despite all those manipulations, these motor scores continue to deteriorate. And that's another hallmark of Parkinson's disease, is that the disease progresses despite attempts at optimizing treatment. So what you can see here is that over these 4 years, the motor disability as measured by the UPDRS score in the levodopa group never really even gets back to the baseline severity before they started treatment, and those on pramipexole, actually at this point these people are on a combination of pramipexole and levodopa, just about gets back to baseline after 4 years. So you can see a very prompt improvement with these dopaminergic therapies, and then there's followed by a slow, continuous decline, which in my mind reflects the underlying neurodegeneration and progression of Parkinson's disease. Now I want to show you another slide, which is the exact same patients, exact same time frame, but not using the UPDRS as the measure, but this EuroQoL, which is a measure of quality of life. What you see here is that there is a short-term improvement in quality of life. That is, when you start these dopaminergic drugs, there is a couple-point improvement in quality of life, and that is sustained for a long period of time. But when you look at how long it takes people to get back to their baseline quality of life, it's somewhere between 2 and 2.5 years, and everyone is back to their baseline. And by the time you get out to 4 years, people are much below their baseline. In fact, they're as much below their baseline as they ever improved above their baseline by the time 4 years happens. So there's a disconnect between this slide and this slide. In the following sense, the motor disability never got back to baseline, in the pink group at least, and just was getting back to baseline in the pramipexole group. But the quality of life was way worse than it was at baseline. So even though we have drugs which very potently improve the motor features and keep them from getting back to baseline severity for a long period of time, that's not entirely reflected in quality of life. That is, these scores do improve when the motor scores improve, but they return to baseline and worsen beyond baseline, indicating that there are causes of disability and diminution in quality of life that are different than the motor scores. There's something about these treatments, and there's something about Parkinson's disease that isn't totally addressed by these treatments.